let's talk about how I assess and diagnose upper cervical instability. If you know much about cervical instability, you will know that people talk a lot about imaging, which is very valuable. But what about over here? Clinical testing. You can weight it more. Some people rely more on imaging. Some people rely more on clinical testing. This is what I do over here, clinical testing. Okay, it allows treatment, assessment, diagnosis of upper cervical instability to be more readily available. We don't need all these fancy tests. We can do clinical testing. How do I do that? Well, I do neurological testing. So that can be sensory reflexes and what we call motor function or muscle testing. And that can allow us to know what is actually happening in the upper cervical spine versus only looking at imaging. Now, of course, do I do some imaging? Yes, when it's needed. But again, as I said, I do a lot more heavily weighted of the clinical testing because I want to see what is actually happening to the patient in terms of what they are experiencing, especially when you're trying to do a correction. So when I am assessing often motor function. And that is how I am going to eventually diagnose upper cervical instability because, as I've mentioned before, sustainability of treatment and neurological function is often how we know, is it just a C1 misalignment or is it upper cervical instability? Now, also when we talk about these two here, they need to correlate. How many times have I seen some imaging that showed what we would think is, say, instability or something of that likeness, flattened curvature, but the clinical testing revealed stability, right? Do they always correlate? The answer is no. And that's why I rely more on this because I want to know what is actually happening and sustaining. The other thing to consider is, what about the different sources of ligament laxity? Now, when we look at imaging, it is only looking at the structural source, one of three types of ligament laxity. The other two we have to find clinically. It is so important to see the whole picture, understanding that there are three major sources of ligament laxity, which I will cover in my next video, and that clinical testing is an integral part of assessing and diagnosing upper cervical instability. If we are only looking at imaging, we are going to miss things. A great example is going to be looking at a disc herniation. Just because we see a disc herniation does not mean it is having a clinical effect. We have seen that for a long time now. Now I could go down a list of things that say, okay, we could look at some type of imaging or testing, and then it does not correlate clinically. Look at the clinical side of things. That is why patients are often surprised at the ease of coming into my office based on cost, based on intensive evaluations. Clinical testing is easy. This is what I teach in my courses when I teach about upper cervical instability, because we want to fix and correct what is happening to the patient clinically, and we can complement it with imaging. So that's a little summary of how I assess and diagnose upper cervical instability.